Hello and welcome to this afternoon's webinar. This is the first of 4 webinars in a series where we're looking at the issue of mental illness, mental health and stigma. My name is Nicola Byrne and I'm the CEO of Shine. We identified key areas as part of our work in recent years and particularly last year based on feedback, research and evidence that we know that how we can make the biggest difference in dealing with stigma in relation to mental health and mental illness. So I'm really excited today to welcome our guest speakers. They're really have a lot to add to the conversation in this area. The reason why we're talking about challenging stigma in health and social care is because it's one of the key areas that's identified for need for further development in addressing stigma in relation to mental health and mental illness. And so, first of all, I want to say apologies. I'm having technical difficulties here. So if you move to the next slide there, Katrina. As I said, my name is Nicola Byrne. I'm the CEO of Shine, and I'm going to hand you over to Trina Fitzpatrick, who's our Head of Programme and Services, and she's going to talk to you about who we are and what we do and why we do the Green Ribbon campaign. Thank you.
Thanks, Nicola, and lovely to be here with you all today. Yes, as many of you will know, Shine was established in 1979 by a group of family members. And we support people with lived experience of mental health difficulties and mental illness. And we also work with family members who are supporting people with mental health difficulties and mental illness. And that's something we've done for a long number of years, and we really pride ourselves in working in this area and the expertise that we've gained over a long number of years doing that. We promote individual recovery for relatives and supporters. It's a unique piece of work that we do, and something that our recovery teams do right throughout the country on a daily basis. We also have a number of programs that we run. This month, as you'll know, it's the Green Ribbon Month, so that's our stigma reduction program. We also have an ambassador program where people with lived experience give talks to corporates in the community. Many of you will be attending those talks this month, and it's a really brilliant experience to hear somebody talk about their lived experience and their recovery. It's just an amazing way to understand that journey, and it's a fantastic program we run. And then we also run our media program, which is a really important piece of work where we work with the media on reporting of suicide and mental illness. We run workshops for media. We have a fellowship, and we also have our Mental Health Media Awards, which are open for entry at the moment. So we're a small but busy organisation, and delighted that you could join us here today. Next slide, Emma. So covering what we do, so providing support. I mentioned there we work with family members and people with mental challenges. We have an information and support line. We do one-to-one support, and we also have groups running throughout the country. Again, our advocacy, the Green Ribbon campaign, and along with that, we have the Voice platform, which is another area for people who have lived experience can bring their voice forward in relation to advocacy and policy, and the reference group, which is where we work with the department in relation to the implementation of sharing the vision. And again, a really strong element of lived experience comes through that. And then finally, education. As I'd mentioned, we work with media. We do education workshops with media. We also have a workplace program, which is where we go into workplaces and will work on how to introduce a mental health policy, and also how to have that really important cultural change when it comes to mental health in a workplace. We run recovery workshops or recovery education courses throughout the country. This is our very well-known Taking Control course, Finding My Way and Exploring My Way. And then our specialist webinars, this is the first one this month, so we're delighted you were able to join us for it today. Next slide, Emma. So why is the Green Ribbon campaign so important? Well, there's a number of reasons for this. One, by wearing the green ribbon, like I have on here today, it's a symbol, and it's a really meaningful symbol that I'm happy to have a conversation about mental health with somebody. And we'll be distributing hundreds of thousands of green ribbons across the country all this month. And it's just really important for people who want to have that conversation to see that visual symbol on somebody else, so they feel feel that they know that they can have a conversation at any time with someone, that's incredibly important. It also challenges negative perceptions, which we know can often be felt by people either through self-stigma or through a negative experience they might have had. And it promotes conversations, and we get amazing feedback throughout the year about how, just a conversation has started from somebody wearing a green ribbon and the huge impact it has had. So the campaign that we're running at the moment, we have a really strong digital campaign, and we've all the digital assets available on our website. We have lots of materials we are working through with community groups, and our recovery staff throughout the country are working on that as well, and also some corporate partners. We are supported by NOSP, the National Office for Suicide Prevention. And so this aligns with broader strategies like Connecting for Life. And we're really lucky to be partnering with the ROSs throughout the country, who are running a whole series of fantastic events. And they're all up on our website to be able to see as well. We'll be updating each week just the different events that we have going on, and particularly on our social media is a great place to find out what's going on. And really the Green Ribbon campaign is, we're looking for change. We're reaching out to people and community organisations everywhere for this social movement to create grassroots change. Next slide, please, Amma. So this is the first webinar we're having as part of the Green Ribbon campaign. We'll be doing them every Wednesday throughout September. The QR code there on screen will take you to our website, and you can either watch back one of the webinars or register for any of the next upcoming ones there by scanning that. So we'd be delighted to have you join us every Wednesday lunchtime throughout September. We have some really interesting panelists today, and the upcoming webinars are the same, really engaging, interesting topics that we're going to talk about. Next slide, please. So handing over now to our panel today, starting with Karen O'Connor.
Thanks very much, Katrina. Thank you very much, Shine, for inviting me. Shine are really important partners for us in the Early Intervention and Psychosis programme, and we really value working with them. And thanks for inviting me to this today. I'm going to talk just very briefly, no slides, just maybe a little bit about the psychosis angle and all of this, and then I understand it's largely a group of clinicians that we're talking to here. So just talking about, why is psychosis so challenging still in the Irish context? I think part of it probably relates, it's multifactorial, but one piece is we have deep historical sediment in terms of stigma and mental health in Ireland. We ran one of the largest asylum systems in the world. In the 1950s, we had the highest psychiatric bed use internationally. That's changed, and policy has changed, and we're moving right out into the community, and that's been underway in the last kind of 20, 30 years. But that legacy is still there, and it still shapes family stories, it still shapes the imagery, and it still shapes policy reflexes and political standing. I'm sure as clinicians you'd often notice that you might be trying to elicit a family history. Somebody's coming, it looks like the presentation is psychosis, and you're trying to establish a clear family history, and actually it can be quite hard because we still use language like nerves and he was a little odd, or and you often have to dig around to kind of get more specific information sometimes in relation to family history. Sometimes we would find clinically that people are sometimes happier if this is drug related rather than being not drug related and mental health. Often there's both, but I think maybe we've moved in certain areas as a society. We're more comfortable talking about mental health broadly, but psychosis still is a bit of a challenge. Even though the amazing work that the Shine are doing, the Green Ribbon campaign, it's really raising the profile of mental health and facilitating conversations, psychosis is still one that's a bit hard to talk about. People aren't comfortable with the language around it. And if you look at the research in this area in Ireland, people still have quite negative connotations in the public around psychosis and around schizophrenia. There's associations with things like unpredictability. And so it's still a lot of way to go there. I think another piece that probably feeds into it and is a real focus for us in EIP, and I'll come back to this, relates to the way that people with psychosis present to services. So it's often in crisis. They're in crisis, their family's in crisis, you're meeting them at a crisis point, everybody's under strain and pressure. It's not a great way to meet somebody for the first time. And certainly in our services, what we find is that people come in that crisis, you do a lot of work to try and support the person, to be clear about what's going on, to try and get them on the right care plan and get the right treatment in place for them and for their family. but because it's been such a crisis and such a stress, often the individual themselves and sometimes their family are like, actually, we're better now. We don't really want to see you guys again. We'd like to head off into the sunset, actually, and we don't really want to tackle this. And that piece around what does it mean for me as a person that I'm experiencing these symptoms? What does it mean for my life? What does it mean for me as a sibling of someone who's experienced this? They're very difficult things to tackle and address. And when it starts in a crisis, I think it makes it even harder. And so, a big focus that we try and do in early intervention is to get people before the crisis, get people in early, and then have a wraparound kind of package for them and then also for their family. And we do an awful lot of work around psychoeducation. Sometimes we're not talking about psychosis for quite a while because people aren't ready to talk about it. And really we're just trying to engage people to have a conversation about where they're at, where they're going. And sometimes I'm talking to someone about sleep for 3 months before I can talk about some of the other things, because that's what they're comfortable talking about. I suppose the other kind of piece, the media piece, Headline are doing amazing work in that space. But it's still hard. It's hard to get that lived experience voice out there. It's hard to get it in a very recovery orientated way. Sometimes it's brilliant when I see, and there's much more of it now, and Shine have really supported this. A number of articles, even the last couple of months, about people talking about their experience of psychosis and how they're recovering and how they're doing well. We do need to hear more of that. A lot of people that would express a desire to do that we would work with would often then decide at the last minute, actually, I'm worried about how it'll impact me, my family. I'm comfortable with it, but my family aren't, or work and all of those things. So it's still a challenge, and it's something we need to keep working on. And I suppose one of the big things for us in terms of stigma is that delay to accessing care. So in early intervention psychosis services, we want to support people as early as possible. That's not just because we want to get in early, it's because people do much better if they do get access to care earlier. So the longer the delay between the person developing symptoms and accessing care, the worse the outcome for people. And then the worse the outcome, that feeds back into the stigma. And then we're stuck in this loop sometimes. So that's definitely something that we really want to tackle, and is really important to tackle. I suppose we see early intervention and psychosis as a model of hope and recovery. Sorry if you've heard this from me before, because it's something that I do reference a lot, but when I started in training, which is now 20 years ago, I have a very clear memory of a young man who was the same age as me, who I saw in clinic, who was having a first episode of psychosis. And at the time, actually, he was studying medicine. So he was someone that I could really kind of identify with. And I remember this family meeting that we had after meeting him. And when I look back on it, it was just so depressing. We kind of essentially, his family were saying, is there any hope he'll get back? The sense was there probably wasn't. There's no point in giving these people false hope. There's no point in giving him false hope. And when I look back on it now, and that was the time, and I'm not criticizing that thing, but it's just, if I was that young person or I was that family and the team working with me couldn't hold hope for me, well, I probably wouldn't want a whole lot to do with them, because I'd want to hold hope. Somebody has to hold hope, and something in our EAP services that we do talk about a lot is the importance of holding hope for people. Sometimes they're not ready for the hope themselves, but it's very important that you can hold it for them, and they can take it back then when they're ready. And so we need to have hope for people, and that's very much part of the cultural kind of piece of EIP, having hope for people, constantly trying to find the solutions, working with people at their pace, and expecting recovery. So yeah, I suppose we have some nice data now coming out of our EIP teams. Some of it is in collaboration with Shine. We have surveys that a national survey that we've done, I think now 3 times, Nicola, is that right? And what we've seen in those surveys is that, that there is still a real challenge around stigma, but actually there are some improvements over time, and that people find that if they can access an early intervention approach, that actually the stigma is lower than if they access a non-early intervention approach. And I think we really need to try and upscale and expand our early intervention services so that they can provide people with that kind of wraparound care that they need. And I think, because I'm talking to clinicians as well, it's important to say, and I say this all the time, if you're working in a non-EIP team, it's not possible to provide a full EIP approach. It's just not possible. You do need to be resourced, you need to be supported, you need to have the access to training and time. Time is a huge element. I do my clinics, I have 30 minutes per patient. That's not how it typically works in other teams. We have smaller caseloads. So that's why it's really important. It's very important that as clinicians, we hold that hope and we do what we can. But in terms of upscaling EIP, that's also really, really important because demand is ever increasing. And we do need dedicated EIP teams to do this really well. Yeah, and I think the other piece, I suppose, to mention is, you know, the economic argument around all of this. So, you know, we know that investment in EIP is really important for recovery and for the individual. It's really important for their family. It's really important for healthcare staff as well, actually, because we know that actually healthcare staff prefer working in these types of environments and where they have more flexibility, where they have more opportunity to do the kind of work that they do, but also that it's an investment in the economy because for they've demonstrated this now repeatedly in the UK particularly, but in Ireland also we have data on this. We have 2 papers published on this, that if you invest in early intervention services, that you save money on recovery for the personal recovery for the individual, reducing admissions to hospital, reducing crisis presentations, but also, and hugely importantly, they stay in employment, they can live independently, and that saves a huge amount of money more broadly into the economy. And so, you know, that's another really strong argument for the investment in EIP. And I think, you know, that would hugely help us to tackle stigma. The final bit I just wanted to say before I hand over was around the work that we do at Shine. The work that Shine does is hugely important in terms of the clinical services and the support that they provide to people. In each place that we have an EIP team, we work really hard to try and work collaboratively if there is a Shine. I know Nicola always says it's like shows, it's almost nationwide, and we're a long way off almost nationwide, unfortunately, in EIP, but we are growing, and we're at 8 teams now funded, so that clinical support is really important. But the other really important pieces are the advocacy and that huge work that Shine do, and we often try and work with Shine around that, and we really value that. And the last piece then is around education. So, and I mentioned at the beginning, a huge piece of work that we do with families and young people who present to us at the beginning is around education. So trying to tackle some of that stigma, try and prevent that self-stigma from festering, you know, and not shifting. And we really value the work that Shine does on that, because that really makes a difference. So you being at Electric Picnic, for example, you know, all those things make a massive difference. So they were the things I wanted to say, and you know, I'm happy to answer questions afterwards. Thank you.
Thank you, Karen. That really is appreciated. I'm trying to call on certain things that you spoke about there that are really important to say. And the message of hope is really important. I suppose we often think about things in the context of the present day situation and treatment and interventions that are available. But actually, it's very important to say that, you know, I've been around a long time in mental health services, and there's been a change, and change is happening quicker. So it's important to offer people hope, because we do not know what interventions and what supports and what difference will be there in 10 years' time. So it is an important message to get across to health and social care professionals. The other thing to say is, you mentioned Headline, and Headline is now our media programme in Shine. We've rebranded, so Sea Change is now part of Shine as well as Headline. But Headline does a lot of work with the media, and thanks for mentioning that, and supporting the voice of people that lived experience at the centre of stories. But in order to do that, I was really struck by the fact that, you know, you're talking about stigma there, but there's the public stigma and the self-stigma. And until we can deal with both of those well, that actually stigma reduction saves money. It's like EIP or early intervention psychosis. These things, there's an economic argument for them, because if people, as you say, seek help earlier, they recover quicker. But the last thing that's really important to say that struck me from when you were talking is, you know, Karen, getting the voice of lived experiences at the centre of this work, and that things like health or insurance when you're going for a mortgage is impacted if something goes forward. So, you know, you're raising some really important points there, and thank you. And we'll come back to this in the Q&A. But I think, you know, there's an argument at the moment around people who've been treated for cancer and then are in remission, and how that, you know, the right to be forgotten around that information. I think we need something similar around mental health and mental illness. So thank you. So next up, can we get the slides up there, please? And next up, we have Professor Jim Lucy. I've been blessed to work with Professor Jim Lucy in a number of different ways. His current role as the Inspector of Mental Health Services is a very important role. I started with them on the board of the Mental Health Commission. I have to say it's always been a pleasure to listen to what Jim has to say on these issues. So without further ado, I'm going to hand you over to Jim and to thank you for being here today.
Well, good afternoon, Nicola, and good afternoon to everyone on this Shine webinar. It's a real delight, a privilege actually, to be invited onto this webinar series. I commend Shine for taking this on and for sustaining initiatives like this. And I think listening to Karen, you know, there's so much to say that that she puts so well. I hope that what I'll have to say will be helpful. Obviously, I was very pleased when Nicola invited me to take part, and she asked me to talk about regulation and human rights and risk. And so I'm going to address some of those questions. But first of all, I just want to say how much how highly I regard Shine and how much I have over the years. I'm in mental health care over 40 years now, and I've seen the work that Shine has done. I've worked closely with ambassadors and I've seen the value of the green ribbon, and it's not a token. It's really a surprising, hopeful development that people are willing to talk now. And we began that conversation in the media. You know, I can remember early times, maybe 25 years ago, going on the radio, and no one was really talking about this in the modern way, the lived experience way, the relevant way that is spoken about now. And gradually we're now talking about things like psychosis and like challenging mental health difficulties. And so you can see the progress in the dialogue, and the conversation is so important, particularly in relation to stigma. Next slide, please. So Nicola asked me to concentrate on a few things. The inspectorate's view of stigma. Well, it's an interesting thing to think about. Does the inspector have a view? Well, I do, certainly, because I'm only recently a gamekeeper. I've been a poacher all my life, and privileged to be at the front line of mental health care in the public and the private sector in Ireland and the UK, and largely dealing with psychosis in the community and with a very challenging mood disorder. And so I definitely do have a view on stigma, which I want to share with you. I think we need to talk about cultural change in the services, and in my current role, and Nicola has referred to this, I'm working with the Mental Health Commission, which is a fantastic body, which really is, among others, but certainly in its own right, taking a lead on a human rights approach to mental health services, which is a cultural shift and is ongoing. And I think you'll be interested in hearing. I'm going to pick out two examples from our inspectorate system. So the old model back to the 1945 Act. So I've worked under several mental health acts. I go back that far. The old model was the school inspector who came along and he made sure that everything was righty-tighty. And it's relatively an effective model. Now we have an understanding that we must do everything we can to enhance and promote healthcare, mental health care in the round, and from a position of human rights. And so that's what lastly I'll talk about a little bit. It will be about the importance of a rights-based mental health care approach. Next slide, please. Well, here's my view. Stigma is the most important barrier to progress in a rights-based mental health care service. There's no other barrier of anything like this. Not funding, not resourcing, not the fears or the challenges inherent to the illness. Stigma is the barrier, and it's surprising when people fail to see that. I can remember, again, about 20 years ago on the radio, one of a really very good advocate, a really helpful advocate in mental health care in terms of broadcasting, in terms of public relations, said to me on air, surely we're not still talking about stigma. And these were live broadcasts I used to do. And I remember being momentarily stumped, because for me, next slide, please, stigma culture is still every time, every place, everywhere. I have a predilection for choirs and singing in choirs, and humming. And I'm old enough to remember a television ad for a drink called Martini. I don't know whether you remember this ad, but I feel a song coming on. It used to go, every time, anytime, any place, anywhere, there's a wonderful drink you can share. Well, I think the ad is not probably familiar to you, but from my mind, it's a little triad that I remember, because stigma appears every time, every place, and everywhere, and often in the most unexpected places. And if you don't recognize it, you probably aren't seeing it. If you don't think it's there, you probably have it. And any of us at any time can find ourselves unconsciously, practically, I would say universally, having to overcome stigmas. Why is this? Because the reason is because stigma is actually a human cultural phenomenon that will always be there, will always be tribal, marking out who is within and who is without. Look around you now. The rise of the right wing in this country and across the world is about regenerating various forms of stigma, saying those are without, those are within. It seems to be a way that people galvanize themselves in society, and it's inherent to human nature to stigmatize. But it's something that we don't need to be overwhelmed by. We just need to recognize, as I say, that it's every time, every place, everywhere. Next slide, please. So here's two examples. They're taken from my more immediate work, not from my experience in mental health teams, which I've worked in all my life, but now as the inspector. So we have a number of regulations, rules, codes of practice that we inspect a small proportion of Ireland's mental health services, probably only 1%. That's to say the proportion that is involved in the approved centres. And I'm picking out one regulation just in particular, the Regulation 21 for privacy. The regulation is very, very clear. It says the registered proprietor, that's to say the responsible person leading an approved centre, shall ensure that the resident's privacy and dignity is appropriately respected at all times. Now, who would have thought that that was a high bar? Who would have thought that that was any way to be questioned? But every day in our inspections, this is one that is questioned. And I'd put it out to you that we question it sometimes as service providers, sometimes as fellow users of service, sometimes as members of the community. We question it largely because of stigma, failing to recognize that every person with mental health difficulty has an inherent human right to privacy and dignity, and that must be respected at all times. It seems to me to be a given, but it's not a platitude. When you see the results of the annual inspection as recently as 24, only 68% of approved centres were compliant with this rule, minimally compliant. A third were non-compliant with even this basic privacy rule. Now we sit down with the service users, the residents in the centres, they call us out. We sit down with the providers, with the workers. I have huge admiration for the teams on the approved centres. I've worked in so many of them and I know so many of them, but I've visited all of them now in my 2 years. And I failed to find anywhere where I wasn't in deep empathy with the providers as well as the cared for, working often in very difficult circumstances. But again and again, I find people saying, but we have to manage this because of risk, or don't you understand? And yada, yada, yada. Anytime, any place, anywhere. I'm humming that in my head as I hear this kind of narrative of dilution of a basic human right to privacy. It's often a caring narrative, one that says, I'm doing my very best. Why are you giving me such grief about a thing like Rule 21? But we can actually take a different approach, a more collaborative approach, and be surprised at the extraordinary achievements that occur. Next slide, please. If you look at stigma and its most dramatic effects, perhaps there's no better example than in our use of restrictive practice. That's to say, the occasions where we hold, contain, restrain, isolate, sometimes have to chemically restrain people with rapid tranquilization. If you just look at two factors, physical restraints and the use of isolation, so-called seclusion, we can consider those restrictive practices over the data set that exists in the Mental Health Commission from 2018 to 24. It's a remarkable data set, rich for anyone interested in seeing the hope that Karen talked about earlier. An enormous achievement has occurred. These practices have reduced both in adult and in child centres. And the scale of the reduction is nothing like anything could have predicted. Indeed, most people said it couldn't be done. In adult centres, these practices have been reduced by 64%. And in the children's centres, by 91%. What's so gratifying is that these reductions in restrictive practice are commensurate with an increase in therapeutic practice, because the time spent in restraining, restricting, isolating has been replaced in these centres by more involvement in therapeutics, multidisciplinary team, in nursing care, and in the rest. And what's happened by reducing these was happening even before we revised the regulations back in 2022, introduced in 23, with a specific human rights focus and a mechanism of near real-time reporting. It's true, though, that heightening of the bar and that immediacy through technology of reporting has led to nearly 1/2 of those reductions happening in the last 2 years. So that people were looking to improve in this way. And when the technology and the definition and the leadership was shown, they took it on. And the centres have themselves made dramatic improvements. Next slide, please. This is simply a bar chart illustrating and counting out the numbers, just in case anyone would be surprised. Over 7,000 of these incidents back in 2018, and now just a little under 3,000. Huge reduction. If you look at the reduction in the children's units, it's down from 2,600 down to 260. An enormous reduction. And this is continuing, and we know that the process of reducing restrictive practice is one that parallels the increase in therapeutic practice, and that is happening in most centres. I would have said out of the 67 centres we inspect, it's probably happening more dramatically than anyone would have countenanced in about 58 or 60 of the centres. You still have a difficulty around the cultural reality in about 7 of the centres. There is some question as to why those 7 centres seem to be so resistant. People have written recently in academic journals that it's to do with urbanization, but that doesn't bear any witness when you look at it. And you see the map itself shows that centres that are in urban settings are doing very well in this, and that some of the settings are the least urban, where the difficulties are greatest. Some people have said it's falling simply because admissions are falling. But this is a fall of 91% in children's units. And anyone who can publish a thing that suggests that needs to probably reconsider their arithmetic. There hasn't been a 91% reduction in children's admissions. And it's not to do with our low level of custodial admission, which has not fallen at anything like that level. No, this is about a genuine shift in cultural practice. And I would say it's actually about a shift in stigma. The idea that we need to restrain, isolate, and contain psychosis in this way is in itself a stigmatic thought, not borne out by the reality. where therapeutic resources are provided. And I accept they're not always provided in every centre. I take Karen's point that not all of us have a richly resourced mental health team with adequate time for consultation and so on. And the same gaps appear across the board. But actually, the progress is not proportionate to resources here. It's proportionate to a shift in stigmatic thinking, in my view, a cultural shift. So just as we still have work to do, the privacy example being a good example, it would be wrong, it would be terribly wrong, not to celebrate from the highest mountains the enormous achievement being made. I think that it's reasonable to call this the largest shift towards human rights-based mental health care that we've seen since the closure of the asylums. I think it's something that the patients themselves, the residents themselves, the service users are celebrating and thanking the staff for. We look at feedback and we hear that. But I think it's also something that needs to be celebrated by the professions themselves, who are somewhat slow to celebrate the progress they're making, but they are delivering the progress. Nurse practice development, for example, is shifting dramatically towards this human rights focus. I think some of mental health care in terms of other disciplines needs to catch up. But overall, there's no doubt that these numbers are indicative of a cultural change, which is in itself an answer to stigma. Next slide. So I think I can't overemphasize the good work that Shine is doing in emphasizing the importance of a human rights-based mental health care service. The right will always be something we have to question. What is the next right? We can't put a barrier to our insight into the way in which we respect each other as human beings. But cultural change of that kind is happening in Irish mental health care, and it's achieved through greater advocacy, to which I give Shine a great deal of credit, and through better standard setting. Of course, further progress is needed, and this will require more sustained public support. I can't emphasize that enough. When you wear the green ribbon, you're not just saying, I'm wearing a token. You are saying, I'll have a conversation, and effectively you're saying, I have public support for this movement. Make no mistake, as the shadows of darker movements across the world grow larger and risk overcasting us, the wearing of the green ribbon is an extraordinarily important public declaration of sentiment. Abraham Lincoln was famous for saying many things, but one of them that I like was that he said that in politics, anything can be achieved with public support, and without it, nothing is possible. So this is in many respects a political statement when we wear the green ribbon. We call out for modern legislation. We look forward to the new act, which in many ways is going to help this momentum, and which we welcome. And of course, we look for the greater investment, which is so necessary, and which still is well short of the 10% of health spend that we've been promised for so long and that we need. But the story is a very hopeful one. And I think the illustration I've made shows where we need to go, but also how far we've come. And in that, I think Shine has to take a great deal of credit. And I look forward to supporting them and being supported by them as we make progress still further. Thanks very much for listening to me.
Thank you very much for that, Jim. And I think, the way that you've used the analogy around accommodation and control and restraint, they are very important issues. And, things have changed a lot. And actually, if you think about it, society has become more violent in general, but to see that dip in the use of containing people using control and restraint in a society that's become more violent, it has to be something else. There has to be another factor come into play, and it has to be stigmatizing ideas and those kind of concepts. So thank you very much for that, Jim.
Thank you.
My next guest, which I have the pleasure of introducing in today's webinar, is Amanda Casey. I have the pleasure of knowing Amanda nearly 30 years, Amanda. And we were students in college together studying to be social workers. I was delighted. Amanda has worked in lots of different arenas in hospitals, in the community, and I was delighted to hear last August when the announcement was made about who the first ever chief social worker of the HSE would be. And I was straight on to congratulate her. But it's really great that that professions are starting to develop the structures such as the likes of the chief social worker. And I welcome Amanda today to talk about how the structural and cultural stigma in health and social care is, and how we can work together to change it. Okay, so thank you very much, Amanda, and I'll hand over to yourself. Thank you.
Thanks a million, Nicola. No pressure then. And all I can say now to start is that I have an awful thirst on me for a martini after gym there. So you'll have to forgive me, as I may need to go for my post lunchtime drinky after this. So look at just again to start by saying a huge thank you to Nicola and to Shine for the I suppose the invitation to come and present at this first webinar of the series. And I'd also like to take the opportunity to congratulate the team at Shine for obviously for all of the work, but the recent triple lock standard that was awarded by the Charities Institute of Ireland. I think it's a real testament to your commitment to achieving the highest standards in your work. And also congratulations on surviving electric picnic at the weekend, which I'm sure was no mean feat in the rain. So I'm just going to give a little bit of a context to my contribution today, and I might just kind of link it a little bit with the work that I'm doing at the moment in terms of the Office of the Chief Social Worker, and specifically around reform of adult safeguarding policy and practice. As Nicola said, I qualified as a social worker in 1996 and I spent over 20 years working in a variety of teams in one of the largest acute hospitals in the country. I then spent some time working as the assisted decision-making lead for one of the hospital groups, which involved a lot of supporting teams to adopt guiding principles from the new Act into their practice and to ensure compliance with that human rights-based legislation. And then, as Nicola said, in August 24, I was appointed as the first chief social worker in the HSE. And again, that primary focus really will be around the reform of adult safeguarding policy and practice. So part of my brief today was to consider how stigma about mental health can appear in services and systems. And in reflecting on it, I've come up with three kind of key areas that I just want to briefly touch on, and then maybe finish hopefully with some kind of ways in which we can all try to challenge stigma in our day-to-day work. So the first kind of area, I suppose, is around structures and structural stigma. I think since qualifying as a social worker, and whilst I've worked with many people who were experiencing mental health difficulties, I've never worked kind of specifically as part of a mental health team. And in some ways, I kind of was thinking about it a lot. And I think structurally, mental health services are always seen as separate or apart from other areas within kind of, health and social care. In the hospital where I worked, and I was part of the infectious diseases team for a period of time, the psychiatric ward, as it was called at the time, and the infectious diseases ward were physically really set apart from the rest of the inpatient units. And I often wondered what message that gave to people who were using those services. And I think that is one way in which stigma appears, is that physical space that we provide supports in, because I think it does send a message about how we value these services and the people who need them. Many of us, as Karen mentioned there, will recall the institutional settings that many mental health services were delivered from. And it's really positive to see recent moves towards improving those physical environments driven by both regulation, as Jim mentioned, and by advocacy groups such as Shine. However, I think the building is only part of the solution. I think what happens inside the building is equally vital in terms of challenging stigma. I think the second area just to touch on is around sort of policy and legislation. And for someone whose job it is to implement a policy, I have a funny love-hate relationship with policy. I think sometimes in the very complex and chaotic environments that health care staff work in, our instinct is sometimes to seek out and cling to a policy to give us that reassurance. And policy is very, very important. But I think no policy will give us all the answers to very complex problems. And I suppose it's kind of a risk if we become slave to a policy. Equally, policies can be weaponized, and I've seen them being used to exclude certain groups or people or to block progress and change. And I think whilst policy and guidance is important, I think it really is the culture in an organisation or a service that either inhibits or supports good practice. And I'll come back to that in a minute, but I just want to take the opportunity, I suppose, to reference two pieces of legislation, which I suppose are very topical at the moment and again can, if implemented correctly, can either challenge or enforce stigma in kind of mental health services. I think the enactment of the Assisted Decision-Making Act in 2023 was heralded as a significant move towards rights-based care and as a move away from an overly clinical view of decision-making capacity. And I think, like any piece of legislation, it is imperfect. And it has certainly been, for me, the catalyst in exposing existing weaknesses in the system. I think that kind of crystallized for me in that really, really challenging kind of balance between self-determination and protection. And I think it's borne out in many health settings and mental health settings where we are tasked with acknowledging the known risk. And in my head, with kind of the safeguarding hat on, the known risk of abuse and harm for people who may be experiencing mental health difficulties, whilst avoiding infantilizing people who are using services and slipping back to that best interests approach. I think in an effort to challenge stigma, we do need to make sure that whilst we remain open to the possibility that people with mental health difficulties can and do face additional challenges, but that we not let it dictate our work with them. I think with my safeguarding hat on, I think Jim had mentioned this whole kind of language around risk and what that actually means. I think, I spend a lot of time talking and thinking about what makes someone more likely to be abused than others. And on the one side, there is context, so any of us can be vulnerable to harm at any particular point in our lives. And I suppose on the other hand, there are inherent risks that we know about and that we have evidence for, which is often linked to either an imbalance in power or a dependence. And then if you add poverty, pregnancy, disability, marginalization, mental illness, age, you can see then how in this kind of intersectional landscape, many of the people we support in our work are inherently more likely to experience harm and abuse. In our work, we'll often come across kind of clinical notes, and it used to really kind of drive me over the edge, they were littered with words like vulnerable and risk, and kind of what does that actually mean? And I think, again, we'd see this sort of, in the chart, we'd see sort of, upset plus, 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 plus. And I think I'll come back to the importance of language in a second, but it's just, again, it's about that sort of those small things that we perhaps do because we're in a rush to record an intervention, but actually can be contributing to forming an idea or about someone that isn't entirely kind of representative of the full picture. I think likewise, the ongoing reform of the Mental Health Act has raised many issues for people using mental health services and people providing mental health services. And unfortunately, reform and change can polarise groups and professions and ultimately can fail to meet the very complex biopsychosocial needs of the people in our care. I think that legislative scrutiny process that's going on must ensure that all steps are taken to challenge structures, policies and practices that enable and support stigmatisation. And I think it's incumbent on all of us in positions of authority that we take purposeful actions to ensure that those statutory frameworks and any national policies that come from it challenge those traditional stereotypes that people with mental health difficulties are either inherently a risk to others or a risk to themselves, and then therefore in need of our intervention in many aspects of their lives. And I think this is particularly important in mental health, where for many people their illness is temporary and their decision-making capacity can fluctuate. The third kind of and final section is around culture. And I think, as Karen mentioned, in order for healthcare staff to provide good quality care, they need the skills, the resources and the supports to do it. And my experience in hospitals, particularly in maybe general acute hospital setting where someone is presenting with a mental health issue, but it's not the reason they were admitted, is that at times staff are ill-equipped to care for someone with mental health difficulties. And therefore their responses are based on fear of maybe doing or saying the wrong thing, a poor understanding of mental health and mental illness, a lack of expertise in trauma-informed care, and a lack of understanding of the need for individualised approaches with mental health difficulties. Like with anything, no two people are the same, so we have to kind of have personalised approaches. I think this can further stigmatise the person and lead to poor engagement with healthcare services. That's another one of my kind of triggers is around when we say a person didn't engage or they were hard to reach. My experience from working as part of an inclusion health service taught me that it is the system, not the individual, that is often the barrier to meaningful engagement. One of the core responsibilities for me as a chief social worker is to support culture change, which is this lovely nebulous term that we all probably have our own sense of what that actually means and what it might look like. And I think, first of all, we have to ask, what is culture? And there is a definition which says that culture is the worst thing that we allow, which I kind of like because it speaks to, I suppose, the ability for culture to change either for the good or the bad. And it talks, I suppose, for me, it infers that we need to work at it and consistently work at it. I think I'm going to just go back to the importance of language for a second, and language in healthcare and in social work, which obviously is my own kind of profession. Language is also a cornerstone of safeguarding practice, and it is again something that multidisciplinary teams can model for the services that we work in. I think just to start, I goes again just to maybe talk a little bit about the adult safeguarding piece. I take and have always kind of taken a very broad view of what safeguarding could and should be. It is about promoting rights. It's about supporting choice. It is about advocating for environments that enable people to make choices. And if and when abuse does occur, it's responding in a way that is proportionate and person-centred. And by that, I mean that we actually actively seek out and listen to and act on the wishes of the person who has been harmed. Their voice needs to be the loudest and heard alongside the voices of the people who know them best. I think for me, it's about sort of safeguarding isn't a verb, it's a way of working, and it should be kind of embedded in all of our interactions. So back to language. Language matters. It carries subjective meaning for all of us, and it's the way in which we try to get people to understand our viewpoint. And when we describe groups of people as the elderly or the disabled, we negate their individual experiences. When we describe them as vulnerable, it can stigmatise, it minimises, it excludes them, and it may in fact enable harm. When we refer to vulnerable people, most of the time we don't explain who we mean, why we're suggesting that they are vulnerable or what they are vulnerable to. As I said, it's a very nebulous term that's used to label individuals and groups, and as such it's pretty meaningful or meaningless, and it can perversely increase the risk of harm and certainly enforces stigma. So what can I do as the chief social worker to challenge stigma? As a person in the HSE with a leadership role in the reform of adult safeguarding policy and practice, I'm under no illusion as to the enormity of the task at hand. As you and Shine well know, any reform, whether it's through policy or culture change, takes time and effort, even more so if we want to do it well. I think in the face of these challenges, I suppose it is possible to feel quite overwhelmed by the task. So I think what we as individuals can do. And firstly, I'd say go back to basics. Since moving into my new role, I've had a few occasions over the last 12 months where I've kind of felt a little bit lost in terms of my focus and my purpose. And what really helped was revisiting my values as a social worker. And I think the core code of ethics, which all regulated healthcare professionals have, can really support us when challenging stigma in our services and in our teams. Secondly, as Karen mentioned, educate yourself. There are lots of resources out there to support you when working with someone who has mental health difficulties. For example, the recently launched HSE Sexual Safety Framework. There are resources around supporting access to advocacy. There is training in supporting decision making and assessment of capacity. There are resources that are available from groups like Shine, and information around how we can meaningfully apply policies like the National Consent Policy, just to name but a few. But I think ultimately what's needed is leadership and the confidence to call out poor practice whenever and wherever we see it. And I think the fact that so many people have joined today is testament to your collective desire to work towards a more positive experience for people who are experiencing mental health difficulties and those who care for them. Thanks very much.
Thank you so much for that, Amanda. I'm really conscious of time. There's 5 minutes left on the webinar. So I think actually to give people a chance around their breaks, I went into the Q&A while you were talking to check, and a lot of the questions that were relevant to the wider group, the 3 excellent presentations have already hit on, which is really helpful. I think some of the issues you've hit on today in your presentation, Amanda, was around the importance of language, or as I say, what's your language? And, I noticed I worked in the health services throughout my career, and that people still use phrases like commit suicide instead of lost to suicide or died by suicide, implying that there's a crime associated with it. There is no crime committed, and it's important to bear that in mind. And also, there's language documents on our website that will help you to think about your language and your language in your workplace and with your family and friends, that encourages people to come forward. There's a lot of information. We have a new website, a Shine website, that has lots of booklets, information, and different ideas for you to have conversations with family, friends, and colleagues. There's also the 6-step workplace program that we have in Shine. And, a lot of people on the call today are in workplaces. And, we talk about othering and, the corporates get involved with doing our 6-step program. I'd like to see more health and social care workers get involved in it. So I suppose rather than go back to the Q&A, because we're tight on time, I would like each of the people in this webinar to just give me one key point or one key takeaway they'd like for people that are on this call or watch the recording. And to say again, thank you for being patient with me with my technical issues. And it just proves that you can do a webinar from a mobile phone these days. And so I'll start with Karen first. What's the one takeaway you'd like for people on this webinar?
I'm going to echo something Amanda said. You know, culture is hugely important. I like that phrase of the way we do things around here. This is the way we do things around here. I think it's, you know, but I'd like to echo something around, you know, what you permit, you promote. I think that's something that all of us can carry with us, you know, as clinicians, and holding hope for people. Sometimes you're in a system that's overextended, there's endless demands, you feel worn down, cynical, you know, there's another, you know, HSC thing has come down, and now you can't travel, and now you can't do this, and now you can't do that. And it can all feel very, very wearing, but actually individually, and you hear this from families and individuals all the time, one kind person, one person who took the time with them, the person who made that extra effort, people are that really matters. So we can all carry that. We have to keep working towards a lower stigma, more hopeful mental health context. Yeah, and we can do something. Yeah. Thank you.
Thanks for that, Karen. Thank you. Jim, what would be the one takeaway for you?
Nicola, it would be to say that change is happening. Cultural change is happening. The results are there. We're there to inspect and to find. And as inspector, I'm very happy to say that the cultural change is happening. I seriously long for more advocacy and more leadership, so that we all not just speak to it, but actually recognize it, celebrate it, and acknowledge that it's there. The professions still need to, you know, move to a position where they can be happy that cultural change is happening, but it is happening. And the results are showing that. And I think the evidence around restrictive practice is perhaps one of the most substantial evidence bases that anyone could have hoped. Look at it, be uplifted by it. Things are changing, and for the better. And I think if we're going to talk about maintaining hope, we need to find the basis for that hope and hold on to it and shout it loud. Things are changing. It's getting better. And we need to take the credit if we have to, but equally to join the band and continue with that progress, because the negative story is very easy to tell. It's very hard to attach a positive and get it heard. So I don't think I'm being hyperbolic when I say this is the largest, the most substantial progress in human rights care since the closure of the asylums, and it needs to be celebrated, and Shine has some credit to take for that.
Thank you, Jim. And Amanda, your one takeaway from today's session?
I think for me, again, it's about that it's often the simple, small things. I think when we look at and we listen to sort of feedback from patient surveys and from, you know, surveys when we seek it out, it's actually the thing that people are least satisfied with is that communication piece. I think even if you're delivering a bad message, it's actually how you deliver it is what people take away from them. And often it is actually the fact that you've sat down, that you've made eye contact with someone, that you're sitting at the same level that they are. Those are the things that really, really make a difference. And that's something that we can all do. That doesn't take extra time. It doesn't, you know, and I think if we all sort of reflect on our engagements over the last few days or whatever it might be, and take that away with it, I think those small changes will be, you know, kind of collectively make a difference.
Brilliant. Thank you so much for that. I just want to finish off by saying to people that we want to grow this beyond a campaign and into a social movement. And if you haven't already got your new recycled, greener than ever green ribbon, please order them. They're free on our website, and there's lots of other content and materials on our website that you can get. So thank you everyone for giving up their lunch today. I hope you all enjoyed it, and we look forward to seeing everybody next week. Thanks to the contributors, to Karen, to Jim and Amanda, and to the team in Shine for all the work they put into this. So take care and have a lovely week. Thank you.
And you, thank you, Nicola. Bye-bye. Thank
Thanks,
you to the
bye-bye.
Shine team. Bye-bye.
Thank you.